textural deterioration will be there in the bone with fragility is increased in the bone, leading to susceptibility to the fractures. But basically, as you must be knowing as a graduate, the bone is composed of material with matrix and mineral phases. Two phases are there, matrix phase and mineral phase. The main component of the matrix phase here is type 1 collagen, which is a fibrillar protein. We'll be having two alpha 1 and one alpha 2 chains wounded in a triple helix. So, and it will be containing all growth factors and glycoproteins. So when we come to mineral phase, it's nothing but calcium and phosphate deposits in the form of hydroxyapatite, that is Ca10PO4 6 times and OH twice. So these two put together having a bone collagen, which is giving tensile strength as well as elasticity, and this mineralization will be giving a mechanical rigidity. So we, having seen this, now we'll go with the osteoblasts and osteoclasts. These osteoblasts, they become trapped in the bone, and then these differentiate into osteocytes. Once these osteocytes, with the cytoplasmic process elongated, they'll be going through and connecting to each other and one another through canaliculi. So now these osteocytes, we are much bothered about these osteocytes because they make a critical role in regulation of the remodeling of the bone. A remodeling process in two forms. One is osteoresorption, that is bone resorption and bone formations. So this osteocyte with the mechanical stimuli then start regulating the molecules in the form of rank. Rank is a receptor activator of nuclear factor kappa B. So this regulates bone resorption, and sclerostin, which regulates bone formations. So now we have two conditions. One is resorption, another is formation, bone formation. When we have two conditions, definitely we will have four criteria. That is, one is increase, another is decrease. So bone either resorbs or that is stopped. Another is bone formation or bone formation is decreased, increased and decreased. So we have two conditions with four situations. So now we take bone resorption. Bone resorption is now carried out by, everybody knows that it is osteoclasts. These osteoclasts are multinucleated and they come from the monocyte macrophage lineage. So now I've already told you about the rank. Maybe I look like, because having talked for about 20 years in college, I may be like teaching, but don't get offended. This is the way we speak in college. So these rank signaling pathways play a critical role. This regulates osteoclast differentiation as well as bone resorption. These rank receptors, they are a member of tumor necrosis factor receptor superfamilies, and they are expressed on the osteoclasts. See these rank parts. Once you see the picture, you can easily understand. So these are expressed over the osteoclasts. These are rank receptors. These are activated by rank L, that is rank ligand. So once both meet, then they'll give an activation. So when rank L binds to rank, there will be intracellular signalings which will be leading to the activation, causing the osteoclast differentiation as well as bone resorption. Now I told you we have two conditions with four situations. The first condition, we are talking about the two situations. One is, I told you, when rank meets rank, then definitely there will be bone resorption. What we need is stopping the bone resorption. So we have osteoprotegerin. That will, it's a homolog to rank. It's something like a competitive inhibitor like. So it lacks that signaling domain. Definitely it acts as a decoy receptor for rank. So it takes over and it goes and meets the rank instead of rank. So finally it blocks it. It inhibits resorption. So that's what is a beneficial part. So rankle is the bad part, osteoporosis is the best part for us. Those situations are maintained. So in the presence of OPG, definitely there is osteoclast inhibition occurs because of the competitive inhibition of the rankle. So in these situations, if you see loss of function mutations in rank and rankle definitely will lead to poor osteoporosis. So now the resorption is inhibited, definitely petrosis activity will be more. So due to failure of osteoclastic differentiation. And the second condition where loss of functional mutation in OPG, osteoporosis occurs, then definitely it leads to juvenile pages, leading to increased turnover, finally leading to fractures and bone deformities. So the two criteria we have discussed about the resorption. Now we come to bone formation part. In bone formation part, so finally these resorption parts, the end part is these osteoclasts, once they are matured, they will produce two types. One is hydrochloric acid and proteolytic enzymes, that is cathepsin K. So this hydrochloric acid, it dissolves the hydroxyapatite, and this proteolytic enzyme part, it degrade the collagen and bone matrix. So both are done. See this picture. If you see clearly, the osteocytes with the rankle and rank. In between is the osteoporosis. If the rankle meets rank, definitely there is severe osteoporosis leading to deliverance of HCl as well as cathepsin K. If OPG meets, definitely this is all inhibited. The other side is the bone formation part. That is, bone formation is by the osteoblasts. They are mononuclear cells derived from mesenchymal cells. So mesenchymal stem cells, these are the molecules, they regulate the osteoblast differentiation. Now the molecules are being stimulated. So those things are core binding factor alpha 1, CBFAI and Osterix. These transcription factors, they promote differentiation of mesenchymal cells into osteoblasts. So this is the bone formation. That is the second situation we are talking about. Here, bone morphogenic protein also plays a big role. And the transforming growth factors, beta superfamilies. They upregulate the CBFAI expressions. So now, if you see, here also, we need much amount of bone formation rather than losing it. WNT molecules, these are series of glycoproteins. They help in encouraging bone formation by encouraging all these molecules. They bind to the receptor complexes, which are lipoprotein receptor related proteins, either LRP5 or LRP6. So WNT molecules meeting these, upregulating it, definitely increases the bone formation. And the same token where we have talked about the inhibition there, here also there is a bad one. So this is sclerostin. So the fine balance between whether the stimulating effect of WNT wins or the sclerostin inhibitory effect, it wins in binding with the lipoprotein receptor, finally gives you a clue whether there is a good bone formation or it is being inhibited. So now the mechanical loading, if there is a good mechanical loading, it inhibits production of sclerostin. And at the same time, once sclerostin is inhibited, definitely there is a increased bone formation because WNT will take over. And at the same way, it increases the level of OPG. So decreases the level of SOST, leading to increased bone formation, and increases the level of osteoporosis, suppressing the osteoresorption, that is bone resorption. So in both ways, either loss of SOST or increase of OPG benefits in decreasing the osteoporosis. So these are all the internal factors. Parathormone or 1,25-dihydroxycholecalciferol, they act by increasing the mobilization of calcium from the bone to the plasma calcium levels. That is maintaining the plasma calcium homeostasis. In the same way, Thyroid hormone increases the bone remodeling, and it is being suppressed by estrogens and androgens. So all these things, they'll either act on Rankel, OPG and SOST, or over the osteoblast and osteoclast activity, that is balancing those things. The peculiarity of the estrogens is by regulating coupling between bone resorption and bone formation. If there is a deficiency of the estrogen, definitely it leads to less bone formation. That is, bone formation fails to keep pace with the resorption, and finally osteoporosis sets in. So now if you see vertebrae, the clinical picture, if you see, the impact is vertebrae, proximal fractures, distal forum, everywhere there may be fractures with the low energy traumas, and patients suffer from pain, limited range of motion, and automatically orthopedic people, everybody knows that the patient stays with us about 2 months or 3 months, and definitely patient will be having psychological symptoms. And fracture associated risk, definitely there will be mortality. Even I have a personal experience. I lost my father last year just because he had an IC fracture at the age of 86 years. Even I wanted to do surgery, I couldn't do because he developed hyponatremia and he could not recover from all these things. So these are the secondary ones. And the financial impact will also be more with the hospital costs and bed stay and surgeries that are required. And there is a serious public health problem also. 1 in 3 and women and 1 in 5 in men also will be affected. And there will be somewhere around the age of around 50 will be more. So it is next to cardiac in the series of problems now we are facing. So 1 in 8 males and 1 in 3 females over the age suffer from osteoporosis, bringing it the peak incidence where 20 years less than what Westerners face. So if you see the public health problem like life expectancy, it is increasing from 65 to 75 over a period of 13 to 2050. At the same time, population projection is also more and more increasing, and we are going to face much amount of problems of these unless they are being taken into consideration seriously. So it shows the normal is equal amount of bone formation, bone resorption should be balanced. If there is increased bone resorption with a minimal amount of bone formations, definitely that is tilting with acute problem of osteoporosis. If bone formation is still more lessened and resorption is too much increasing, definitely it's going to have a sustained bone loss. So causes you can easily see and you can easily understand also. You know all these things: alcohol abuse, high salt intake, smoking, vitamin A, immobilization. All these things definitely lead to osteoporosis. And other causes are genetic causes, hypogonadal, endocrinal, GIT. All these things will be leading for osteoporosis. So having seen all these things, what is the criteria with which we face the situation and follow? That is history, where we have seen the clinical risk factors in the previous slide, then going for the physical examination proper, and assessment by BMD or vertebral imagings, and finally biochemical markers which help us to go for treatment for the patients who are susceptible and we get suspicious about. So in the physical examination, you can see if you make the patient stand near the wall occiput distance, it indicates the kyphoscoliotic deformity, that's a bend at the thoracic lumbar spine where there may be a fracture. Or it is the distance between rib and pelvis where you can easily keep your 4 fingers, but it slowly comes down to 2 fingers. That means that it is a definitely osteoporotic fractures. So when do we say in BMD, bone mineral densitometry, if you see, it is the value more than 2.5 standard deviations below the average in young healthy subjects. It is T-score we call. It is less than minus 2.5, they're osteoporotic. If it is between T-score is minus 1 to minus 2.5, osteopenia. If it's minus 1 to plus 2.5, it's a normal bone mass. And if it's more than 2.5, we should think that it is abnormally high bone mass. So the same thing is depicted here. So when do we go for BMD testing? That's routinely women aged more than 65, men aged more than 60, young postmenopausal women where there is a clinical risk fractures or fractures, women in menopausal transitions, men aged around 50 to 70. So adults who have fractures at the age and in and around 50 also we should go for that. Or any patient on glucocorticoids or rheumatoid arthritis. So this is how we test dual energy X-ray absorptiometry, where you can see the red line where we can go for the femoral neck assessment of bone mineral density. Or in case of lumbar, from L1 through L4 we can assess. So we have two scores, T-score and Z-score. So T-score is nothing but a BMD value when it is compared to that of a control subject who are at their peak BMD. So if you see the Z-score, it is the BMD value compared with the persons matching their age and sex. First is perfect, who are at their peak. Second is matching with that same person, age and sex. That is Z-score, both done by DEXA. So vertebral imaging also being done. That vertebral fractures, if you see in vertebral imaging, then immediately it is a sign of impaired bone quality. You can see a lot of aged people having vertebral fractures. So we call senile osteoporosis leading to fractures. That is wedge compressions. And strong predictor of, again there may be a new vertebral fractures in years to come. And it is performed using taking a lateral view, not an AP view, lateral thoracic and lumbar spine, lateral vertebral fracture assessment also being done. And presence of single vertebral fracture always gives you an idea that there is going to be a hip fracture or another fracture within few months or years in a twofold or fivefold. So when do we do vertebral imaging? That's women aged more than 70, normally all men aged around 80. And with T-scores, it's a -1. If less than -1, 1.5 T-score, definitely even at the age of 65 to 70 in females and 70 to 80 in males, we go for vertebral imagings. All postmenopausal women with the age around 50, where there is a low trauma fractures with minimal injury also if they're sustaining fractures, or historical height loss of 1.5 inches or more, or prospective height loss of 0.8 inches more, we go for that, or glucocorticoid treatments where the patient is taking. The most important one we have come to is biochemical markers. These are the most important ones, which can be assessed biochemically by analysis of bone cell specific proteins or products of matrix formation and degradation. They are released during bone remodeling. So we assess these biochemically. This is bone cell specific proteins are products of matrix formation and degradations. So the investigations clinically in three main areas. One is predicting rates of bone loss. That's what we do. Second is predicting the response to treatment, how it is responding. Third is assessment of compliance to medication. This is the way it helps. So these are the things. Bone resorption and bone formation, both are assessed with the markers. The first one is telopeptides, collagen telopeptides, that is C-terminal cross-linked collagen telopeptides of type 1 collagens. And these are all bone osteoclast numbers. See, this is because bone resorption, we assess the osteoclasts here. When we come to bone formation, it is the bone-specific alkaline phosphatase, or again collagen propeptides. These are N-linked or C-linked, C-terminals. This is also cross-linked. So this is osteoblast numbers we assess. So those are for bone resorption, osteoclast numbers we assess. It's a bone formation. It is the propeptides for osteoblast. Another is we have fracture risk assessment tool, FRAX. This is the most important one apart from BMD. FRAX tool developed by WHO. It evaluates the risk of the patients. It has got this algorithm. It's a very useful one. It gives a 10-year predictability or probability of the fracture. If you see the risk factors, like if you assess all these things in a format, I'll show the format. Current age, gender, prior osteoporotic fracture if any, femoral neck, bone mineral density, low body mass index, oral glucocorticoids taking, rheumatoid arthritis, smoking, alcohol, secondary cause of osteoporosis, all these things, osteogenesis imperfecta. Once you take it in this format and take it, we can assess for the next 10-year probability of fracture. That's an important tool. Additional ones are, we have CT based also is there. CT based absorptiometry is there. Trabecular bone score is there. And peripheral dual energy X-ray absorptiometry is also there. DEXA for peripheral. Or it is quantitative ultrasound densitometry. Ultrasound also it's developed. So all these things with which we can assess and predict. So when I see, naturally it is for the age between 50 and 70, they recommend 1000 milligrams per day of calcium, over 51 and age of up to 72, 1200 for the women. So that is for the men, that is for the women. So in case of vitamin D deficiencies, we give higher doses. This is normally recommended ones. So you know everything, prevent falls, cessation of tobacco, avoidance of excessive alcohol intake, regular weight bearing, all these things, exercises, those are needed to prevent all these things, osteoporosis. So when we see therapy-wise, where we need to give medicines, vertebral fractures are fib fractures, T-score less than minus 2.5 they need, or low bone mass between minus 1 to 2.5 T-score, or 10-year probability of fib fractures if it is more than 3% based on Frax algorithm. Already I told you Frax algorithm. This is our 10-year probability of major osteoporosis, more than 20% based on Frax algorithm. All these people need some sort of medication. So drugs, the available drugs are divided like this. Anti-resorptive, where it stops resorption, that is like osteoporotiserin. Another is anabolic agents and other agents. All these things you must be knowing: alendronic acid, ibandronate, zoledronic acid, denosumab. All these things you must be knowing. So we use all these drugs. Actually, they have a beneficiary. Like alendronate, we give weekly. Residronate, ibandronate, we give monthly. Zoledronic acid, we give injections once in a year. And denosumab, once in 6 months. And teriparatide also, it's useful. Now, strontium ranelate, this is a very good drug, actually. It inhibits bone resorption as well as it promotes bone formation. Both criteria are fulfilled. So evidence shows there is 37% reduction in vertebral fractures and 14% reduction in non-vertebral fractures, and after 5 years it's more, 43% reduction in hip fractures. So gain in BMD, bone quality improvement is there, and it has got a sustained efficacy and long-term safety is also there with the strontium ranelate. Now if you see, I have already discussed sclerostin. That sclerostin stops bone formation. Anti-sclerostin, where it is osteocyte-derived inhibitor of osteoblast action, which is sclerostin's work. So that can be stopped by romosozumab. So this humanized monoclonal antibody, it inhibits sclerostin, helps in improving the bone formation. So it has got a dual effect also, stops resorption, improves bone formation. Significant improvement is there with hip bone strength, and it have got a better is compared to bisphosphonates. If you see denosumab, it's a fully humanized monoclonal antibody directed against rankle. So it is almost like a competitive inhibitor, like osteoporotiserin, stimulates, stops bone resorption and stimulates bone formation. It has a powerful inhibitory effect on bone resorption. It should be given subcutaneously once in 6 months. So here, with the help of denosumab, we have vertebral improvement, reduction in fractures of vertebral body by 68%, hip fractures by 40%, and BMD increase by lumbar spine 21%, totally by 9%. So this is the advantage with the denosumab. We have parathyroid hormone related protein also there, abaloparatide. It's a novel, and it has got anabolic agent for postmenopausal osteoporosis. This got a lot of advantage compared to, it increases BMD from baseline, and compared to placebo it reduces the fractures, and compared to teriparatide it reduces the major osteoporotic fractures. It has got a lot of advantage, and active phase 3 studies is going on. I told you there is a cathepsin, which major osteoclast-derived proteolytic enzyme. It eats away the type 1 collagen and bone matrix. If it is stopped, that is inhibitor is used, definitely it will increase the bone mass, improves the bone microarchitecture. But the only problem is it is being stopped now because that is the one is Bodonacative, CAT-K inhibitor, but it has got a problem because there is increased risk of stroke. Now it is temporarily stopped for reassessment. So finally, to conclude, osteoporosis is a condition with significant morbidity and mortality. And there is a lot amount of revolution in the past decade regarding osteoporotic diagnosis as well as therapeutics. Much success achieved is due to enhanced understanding of basic bone biology. This is why I have taken a lot of your time regarding biology and pathogenesis, because that gave the success to the therapeutics. So bone density remains most valid and reliable measure of fracture risk, and FRAX is the most important one. It really enhanced the understanding of us regarding the treatment and identifying the fractures. So there are a number of medications are available. But the problem is, though they have advantage, they have disadvantages also. Suppose take the case of bisphosphonates. Though they help in therapy, long-term safety is questioned. And whenever you use bisphosphonates, most of you must be knowing, you have to sit upright and take an empty stomach. You should not take any food, at least for half an hour or 1 hour. That's the problem with that one. Teriparatide, you don't know how long, different period of time, it's very difficult to assess. That you should give only for a particular period. You cannot give for any length of time as you please. Raloxifene, it has got deep vein thrombosis and embolism and hot flushes for women. That's at the in and around menopausal age. That is the problem with that one. So there is a need for a drug that could have high safety, increased bone mass, but improves biomechanics with reduced fracture risk. At the same time, should not have much side effects. New and potentially highly effective agents may offer novel therapeutic tools to counteract osteoporotic agonies. That we hope so. Thank you.